A warm welcome, everyone. This is SM Abdullah. I'm a member in Health Economics Research Network and a fellow in ARK Foundation, Bangladesh. I appreciate all your kind presence despite the busy schedule. On the capacity build-up front under the umbrella of Health Economic Research Network, this is actually the first ever webinar arranged by this network in collaboration with Centre of Health Economics in the University of York and DiaDeM project. Today, we have the honor of presence of Professor Tim Ensor and Dr. Bryony Dawkins from the University of Leeds, UK, as speakers of the webinar. Besides, we also have the privilege to present Dr. Simon Walker from Centre of Health Economics, University of York, UK. As an organization of the webinar, we first would like to invite Dr. Walker to share the role of Centre of Health Economics in capacity development of young researchers under this network. Followed by, we will invite our respected speakers. Professor Tim will discuss the role of health economics in helping to understand and evaluate health systems and health system intervention, while Dr. Dawkins will then discuss the type of economic evaluation. The presentation will briefly outline some of the techniques and tools from the understanding sources of funding and funding flows through analysis of equity, economic evaluation, provider payments. So without much further ado, I would like to now request Dr. Simon Walker to just briefly tell us about the role of Centre of Health Economics and the Health Economics Research Network in terms of building capacity for the young researchers. It's over to you, Simon.
Yeah, thanks very much, Abdullah. Yeah, I'll keep it brief so we can get on to the main speakers today. But I'd just like, well, first of all, thank you for the opportunity. I'd just really like to congratulate Professor Hook, Abdullah, and colleagues at ARK for all their hard work in establishing the Bangladesh Health Economics Network. The Centre for Health Economics at the University of York is very proud to support their endeavours as part of our commitment to support the growth of global health of health economics globally. Our support's been made possible thanks to the DiaDeM project funded by the NIHR Right programme, and in which it's a project in which the ARK Foundation and CHE are working very closely on leading the health economics component. CHE's got a long tradition in global health economics research. Tim is actually one of the founders of global health economics in CHE. And we're very proud to continue that tradition supporting this network. We have, recommend that you have a look at the CHE web pages. We've got opportunities for training, PhDs, other opportunities to engage with us. We'd love to hear from you. In terms of, the Health Economics Network is aiming to bring together academics and policymakers, mainly from across Bangladesh, but also to bring in colleagues from the UK and elsewhere internationally, with the aim of building health economics research capacity within the country. And the hope is that will lead to better research. And the reason we want better research is to have better informed policy with the long-term aim to improve population health. And that's the real aim of this network. And obviously it's just the sort of starting steps, but we hope that this can go from strength to strength. I think as Abdullah's mentioned, today's the first in what is aimed to become a regular series of webinars, which will provide training and knowledge exchange activities for health economists in Bangladesh and elsewhere. And I'm very glad that my colleagues from the University of Leeds have agreed to give the inaugural one, and I'm really looking forward to their presentations. So thanks for that, and I'll pass back to her.
Thank you, Dr. Simon. It has been nice to have you here among us, and you nicely mentioned the role of Centre of Health Economics in the front of capacity build-up under the umbrella of HERN, and we are really looking forward to have this kind of event in a regular manner in the future time. So without wasting some more time, I would just like to request Professor Tim to present his views, and followed by I would like to request Dr. Bryony to share her thoughts on these health economics tools. Over to you, Professor Tim. Thank you.
Okay, thanks very much. Hopefully you can see my screen. Is that right?
Yes, Tim, we can see it. It's
okay,
clear.
Thanks. So this presentation actually comes out of a presentation we gave a few weeks ago within our Chorus program, hence the logo, which focuses on improving urban health in Bangladesh and three other countries. And what we've been thinking about is it's definitely an overview presentation, because what we were trying to begin to do is work out what kind of health economic tools and approaches would be useful to assist us in designing and evaluating health system interventions. And that specifically, that was within Chorus, so focused on urban health. But this, of course, these tools and approaches, of course, have a broader context. You know, they can be used at a health system level in any country. So Romana, I think, thought that it would be useful to share a similar presentation with you today. So I'll briefly overview the tools with a few comments, and then I'll hand over to Bryony to focus specifically on the economic evaluation part, the value for money part. We've divided the tools and approaches really into 4 groups, starting at the top of the system and then working down. So really trying to answer different questions that are related to understanding the current context, and then also understanding how an intervention, and by an intervention we might be talking about a treatment for a new disease, or we might be talking about a restructuring that a health facility runs, or you know, one of many different types of interventions. So we've thought about the types of tools and approaches that can help us to understand those problems. So firstly, we've thought about the tools that might be useful at the level of understanding how resources are mobilized and utilized. Second, the tools that are available for understanding how the resources are allocated, particularly in relation to equity. Thirdly, whether the interventions that we're designing to address the problem offer good value for money. So we turn to economic evaluation. And then finally, but also important, addressing how the incentives that are incorporated into the system, how they encourage or discourage the types of interventions that are being created as part of, well, in this case, a part of our urban health project. But as I say, it's applicable to any intervention, I think. So what kinds of tools are available to think through how resources are mobilized and utilized? I think there are 3 complementary really we might describe as public expenditure management tools that can be useful. The first one are the national health accounts. And our national health accounts are essentially a description of the public and private sources of funding, and how those resources are distributed and to which providers they benefit. National health accounts, as the name suggests, are conventionally developed at a national level for the whole country, but there's no reason why this type of approach should not be adapted and used at a regional level, or, as the case for Chorus, at a city level, to look at the way in which resources are sourced for urban health. The national health accounts, as many of you know, has a long history in Bangladesh. I think that first NHA in Bangladesh was produced around 20 years ago, and they have been in Bangladesh. They've been really useful for understanding both government spending and also non-government spending, so private and NGO spending. I found, and I think we found in Chorus, that the national health accounts can be a useful general typology for understanding what's going on in the public and private sector. So outside looking only at expenditures, it can be a good way to understand what kind of service provision are available and how to divide that up by into public, private, NGO sources. We've been doing that a bit within Chorus to understand the types of services that are available at the city level. Now, the second complementary tool are the public expenditure reviews. So this is beginning to drill down a bit below the level of description of sources into understanding particularly how public budgets are formulated. And I think in Chorus, we're realizing this is a really important part of our understanding the context in the urban areas we're working within. We need to understand how the budgets at the local government level, for example, are formulated, what kind of processes are gone through in order to reach the priorities that are put into place. And we see this as a really important part of our investigations, because if we're going to develop sustainable interventions for urban areas, we need to know how to get those interventions into the public budgeting cycle. And public expenditure reviews are a big part of that. Again, PERs have a long history in Bangladesh, going right back into the middle 1990s. The first public expenditure review was undertaken by the Health Economics Unit in Bangladesh. So a long history, a lot of good experience then. And then the third tool is the public expenditure tracking tool. And this is drilling further down again. And the PET is really a tool for looking at what actually happens to resources once they are allocated through the system. So we have a plan within a public expenditure review, the budget. We know to what extent that plan was implemented maybe last year. The public expenditure tracking tool is an active tool for understanding what resources actually get to the priorities were planned and why. If in the case that resources go amiss, what go astray, why is that the case? And public expenditure tracking tools are typically not only used for financial resources, but they're also just as important for non-financial resources. And a big part of the investigation of many PETs, including in Bangladesh, has been to look at staffing flows. Look at the issue of ghost workers, for example, staff that appear on the books but actually aren't actually there available in a facility. So a PET can be a really useful tool for understanding what's going on within the system, what's going on at the facility level. Okay, so that's the first group of tools that we think are really, really important health economics tools for understanding the context. The second group relate to equity, and essentially it's addressing the question, what are the implications for equity of current funding, but also future funding? So if new interventions are introduced, what are the likely distributional implications of those interventions? I think there are two types of equity tools that are useful. Firstly, looking at the equity in the source of funding. So this is understanding who pays the burden of the resources going into health and healthcare. And here there are a range of tools we won't get into now, but there are a range of tools that are useful for understanding overall average payments, such as the Kakwani Index and other tools there. And there are also the tools for understanding the catastrophic spending. You know, what happens to what extent are households financially crippled as a result of having to spend out on healthcare. Both of these types of tools have become quite common within the health economics literature and can be really useful for understanding burdens. Often the results are sometimes different from what we expect. User charges, for example, are often thought to be extremely bad for equity, and mostly that's true. But in some countries, some contexts, the evidence has shown that actually user charges are relatively fair. For example, Sri Lanka is one example of this, where because of the complex system of waivers and exemptions, the user charges are actually borne mostly by the relatively rich, which makes it a relatively fair form of funding, at least within the public sector, not so much for private services. Another example of where this tool might be useful is understanding the impact of payments for community insurance, such as the SSK in Bangladesh. Now, often, again, the community insurance can turn out to be quite an unfair form of funding, because typically premiums are fixed for all income groups. But of course, that depends where the money comes from. And with SSK in Bangladesh, most of the money comes from government. So the equity consequences are a bit different. So that's the source of funding. The other useful set of tools, as far as equity is concerned, is in the allocation of funding. So that's at understanding what happens to the resources when they're allocated through the system and which groups benefit from those resources. A hugely important tool here is the relatively simple tool of benefits incidence analysis. And this basically tries to reflect how far different groups by gender, by age, by socioeconomic groups, to what extent do those groups benefit from the public allocation of resources. This kind of analysis can often be really revealing. The first BEIA I ever did was actually also in Bangladesh just over 20 years ago. And we undertook a study as part of the health economics unit. And we found that, contrary to what was intended, it was often the poorest groups that were benefiting least from the public allocation of resources. When we drilled down a bit, we found that one of the reasons for that was that often the poor couldn't get to the facilities at the right time. They often weren't accessible, geographically accessible, or the facilities was only available at certain hours of the day when they couldn't take time off work to get to the facility. So a whole range of reasons. But these tools can be really useful for understanding what the current position is, but also forecasting what will happen if we bring in new interventions. To what extent are the groups that we hope to benefit from those interventions really going to benefit from them? So that's the second group of tools around equity. The third group of tools, I'm not going to dwell too much because Bryony is going to come back to this in a minute, but essentially it's around costing and also cost effectiveness analysis. So firstly, understanding the cost of the resources that need to go into an intervention is clearly a key question if you're going to begin to introduce an intervention. Budget makers, the policy makers are going to need this information in order to budget properly. You're also going to need this information if you're going to understand how to scale up an intervention. But costing, of course, is only one part of the broader economic evaluation. And economic evaluation is essentially a whole a cluster of tools for understanding whether spending on a particular intervention or service offers the country or the health system good value for money. Is it the best way of spending limited resources? As I say, Bryony will come back to this in a minute. And then finally, the final group of techniques that I wanted to mention was around incentives. So once we've done our economic evaluation, we've decided that an intervention is good value for money, then we've got to implement that intervention. And in order to implement the intervention, we need to be sure that the incentives are in place, that the intervention will be introduced properly. So I think we've got a couple of issues here. The first is around how we set up the provider payment mechanism. So how do we reimburse providers for the intervention that is going to be provided as part of the rollout? I've noticed in many countries, doesn't apply particularly to just to Bangladesh, but many countries, that systems often flip from one poor system of payments to another poor system. So just as an example, often publicly funded systems have relatively weak systems for ensuring that providers deliver services to the right groups of people in the right quantity and at the right quality. Often providers maybe get a fixed budget, and that budget isn't incentivized at all to deliver higher quality services. Often when systems change, the provider payment system can also flip to another poor system. So often what happens is that insurance systems might be introduced and they flip to another type of bad system, which is often the fee-for-service system, where providers get paid for everything they do, whether or not the services that are provided are effective and useful for patients. So Usually a hybrid system is needed, a midway system is needed. And it's very important when implementing interventions to understand what that hybrid system should compose of, what the contracts for providers should include. So that's what the reimbursement of the supply side of providers. The final issue that I wanted to mention, and this has become something that's increasingly recognized over the last couple of decades, is the importance of proper good demand side incentives. So this is ensuring that there are incentives for individuals and patients and households to use the services that are effective, maybe in the case of a new intervention, for using that new intervention. This is something that I was won over to when I was doing some work in Nepal about 15, 20 years ago, when we realized that one of the big barriers to using maternal health services in Nepal was the cost of transport, was just getting to a facility. Nothing to do with the payments once they're at the facility, but just getting to the facility. We did a study on this. We found out that individuals were often incurring huge transport costs and other costs before they got to the facility. And a policy was introduced by government, initially called the Maternal Incentive Scheme, later renamed the AMA scheme, which provides payments to women to get into service providers. So this is another important element of the jigsaw in ensuring that the incentives are in place to allow people to use, to ensure that interventions are used correctly. So those are really the 9 tools that I wanted to present. The questions that can be answered by these tools are numerous, and I've just on the final 2 slides before I hand over to Bryony, I've just clustered these tools really into 2 groups. Firstly, the tools that can be really helpful in understanding the overall context. So if you're doing a needs assessment to decide what kinds of interventions, what are the policy priorities and what kinds of interventions are needed to address those policy priorities, then there are a number of questions that you might want to ask, and tools are available, health economics tools that are available. So firstly, the first part of the context is asking what resources are available to the health sector for the intervention of interest, and sub-questions: how are the resources divided up between levels? Do resources budgeted for health services get to the right place at the right time? Now here, I think that the important tools are the public expenditure management tools that I mentioned on the first slide, that can help you understand what resources are available, how the budgets are set, and whether those resources therefore are going to be available for the interventions later. The second issue then might be who currently pays for health services, and what is the impact of current interventions and maybe future interventions on different population groups. And here we have the equity tools, so the tools that I presented on the second slide. Then if we move to designing the intervention, so this is as we move into, well, firstly maybe a co-creation of an intervention, and then the implementation and the evaluation of the intervention, then other tools become important. So firstly, if we're thinking about which services interventions should be funded, how should those interventions be organized, tools of costing and cost effectiveness become really important. When we're thinking about how providers and patients should be compensated to incentivize them, then of course the tools that I presented on that last slide, provider payments, demand side financing, become important. Who receives the benefits? Equity analysis may also be important in understanding who receives the benefits from the new improved intervention. And then finally, how do we scale up? So once maybe we've done a pilot of an intervention, there's then the really big question of how much would it cost to scale up an intervention? This stage is actually often missed within our projects. You know, as researchers, we think about doing a pilot, doing a nice evaluation of that pilot, and we prove maybe that the intervention is cost effective. But we miss out this final stage, which is the really important one of scaling up. Now, of course, there are a lot of issues around scaling up, but as far as the health economist is concerned, one of the big issues is how much would it cost to scale up, to go from part of a city to a whole city, from one city to many cities or many parts of the country. And they're proper costing analysis that goes beyond the costing you do within an economic evaluation, but looks over time and how much it's going to cost both to the budget and also the country as a whole is going to be really important final stage in our work. Okay, so I'll leave it there and I'll hand over to Bryony, who's I think going to flip back now and look specifically at some of the economic evaluation tools. Bryony.
Thank you, Tim. As Tim said, I'm going to talk a little bit more about economic evaluation and the types of analysis that we might consider if we're interested in evaluating whether a proposed intervention offers good value for money. As Tim said, this presentation is one that we delivered a few weeks ago for our Chorus project, and the idea was really to give an overview of the different options that we have for health economic analysis that we might want to consider in our projects. So the idea of what I'm going to talk about is just to give an overview of what the different options are for economic evaluation and some of the things that we need to think about if we want to undertake an economic evaluation to evaluate our interventions within any of our projects that we might be undertaking. So what do we actually mean when we talk about economic evaluation? Well, a sort of textbook definition is that it's an evaluation that facilitates comparisons between alternative healthcare programs, treatments, services, or interventions in terms of both their costs and their consequences. And what that means is that in an economic evaluation, these two components, both the costs and the benefits or the outcomes, are compared simultaneously, so that in making a decision about which of the alternatives is the best option, we consider the costs and consequences of each option and evaluate their relative merit. So to assess the value for money, we have to assess the benefits and the costs together to assess whether the benefits that the intervention provides are worth the costs associated with delivering that intervention. So in an economic evaluation, we're addressing the question, does the intervention provide enough health benefit to justify the costs of providing or obtaining it? So that's this idea of measuring the value for money. Okay, so why is economic evaluation important? And why should we consider doing this sort of analysis? Well, it's important because no healthcare system anywhere in the world has achieved levels of spending on healthcare provision which is enough to meet all of its population's needs and wants and demands for healthcare. And what that means is that there's limited resources for healthcare, and so decisions have to be made about what should be prioritised to meet healthcare needs in the best way possible. And so economic evaluation is important because it can be used to provide evidence on the best way to use the resources that are available to meet the healthcare needs of the population. So it's a really powerful tool to motivate healthcare decision making and investment. It can also be really important in encouraging advocacy for healthcare treatments, strategies and interventions that can effectively improve population health. So if we want to do an economic evaluation, there are a few main techniques that we could consider. We could consider a cost minimisation analysis, where the alternatives are considered equivalent in terms of the benefits or outcomes, and so only the costs are compared. If there are possible differences in terms of the benefits and outcomes between alternatives, then we might consider a cost effectiveness analysis, a cost utility analysis, or a cost benefit analysis. In each of these, both the benefits and the costs of alternatives are compared, but the main difference is in the way that benefits are measured. So in cost effectiveness analysis, the benefits are measured in physical units. So that's health outcomes that can be directly measured, like changes in blood pressure or lives saved. In cost utility analysis, the benefits are measured in weighted units, which in practice usually means QALYs or DALYs. And in cost benefit analysis, the benefits are measured in monetary terms as well as the costs. So we'll have a look at each of these slightly more detail. So the first sort of minimum option, if we want to undertake some kind of economic evaluation, is a cost minimisation analysis or costing analysis. This approach is not really an economic evaluation by that textbook definition that I sort of showed on the screen before, because only the costs of the alternatives are compared and not the benefits. Because in cost minimisation analysis, the outcomes of alternatives are assumed to be equal. And so only the costs are compared, and the aim is to identify the least costly approach. But for us to sort of justifiably only consider costs without also considering the benefits in an economic evaluation, we do really need to have some evidence that the intervention is equally as effective as the comparator, or at least not inferior. But if we can do that, this is clearly a much simpler and less resource-intensive evaluation, and evaluating the costs can still provide useful evidence as it allows us to quantify the investment needed to implement the intervention and inform scale-up. So it can be a really good starting point. And I would just say that all of the rest of the economic evaluation approaches that I'm going to talk about after this build on this sort of minimum costing approach. So it can provide all of this evidence, but also take it further, because by jointly analysing the costs and benefits associated with an intervention together, they also tell us the cost effectiveness or the value of treatment alternatives, so that the best strategy can be identified. So the next option for an economic evaluation is to undertake a cost effectiveness or cost utility analysis. In fact, these two are the same type of analysis, and cost utility analysis is actually just a specific type of cost effectiveness analysis. In cost effectiveness and cost utility analysis, we aim to measure the cost per extra unit of benefit generated by the intervention compared with the comparator, which most of the time is usual care or standard practice. And in both cases, the benefits are measured in health-related units. The only difference is that in cost effectiveness analysis, the health-related units are directly measured health units, so something that can be observed in natural units from patients, like deaths averted, cases detected, days free from sickness. Whereas in cost utility analysis, the health benefits are measured in composite units of health benefit, which combine quality and length of life. And in practice, that usually means we're going to be using quality adjusted life years or disability adjusted life years. So in this type of analysis, whether it's cost utility analysis or cost effectiveness analysis, we determine whether a new intervention is worthwhile or cost effective by producing a summary measure called an incremental cost effectiveness ratio, or ICER, which measures the incremental cost of an activity relative to its best alternative divided by its incremental effect. So the ICER is calculated as the difference in costs divided by the difference in benefits of the alternatives being compared. And this allows us to compare the relative cost effectiveness of alternatives to identify the best option. So the final option for me to talk about in terms of economic evaluation is cost benefit analysis, where the net value of different services or programs are compared by converting both the costs and the benefits into monetary terms. So in cost benefit analysis, we determine whether an intervention is worthwhile or cost effective if the sum of the benefits is greater than the sum of the costs. So if the net benefit is greater than zero. And this is really useful because if this type of summary measure can be produced, it's really easy to interpret. The problem, though, is that cost-benefit analysis requires the monetary valuation of health outcomes, which can be problematic because it can be difficult to put a monetary value on health outcomes so that we can compare them to the costs. There are some approaches to doing this, for example, by linking health with ability to earn money, but this can really underestimate the value of the health benefits because obviously health provides more value to us than simply allowing us to work. It has a value in and of itself, which unfortunately isn't very well captured by this approach. So we have these different types of evaluation, but how do we decide which might be the most appropriate for our projects? Well, the answer is that there's not really a straightforward answer, and there's lots of different things that we might want to consider. So we might need to think about what outcome to use in terms of what will be the most appropriate for the research question, but also what's going to be feasible for us to collect within our studies. We also need to think about who will make the decision or use the evidence that we're going to produce, and what evidence is needed or will be most useful for decision makers in our context. And we also need to think about the benefits of the different options that we're comparing and whether they are limited to the health sector or whether some of the benefits and costs fall outside the health sector, because this has implications for what type of analysis is going to be feasible or best able to incorporate these different benefits. So in general, if benefits of an intervention are limited to the health sector, then cost effectiveness or cost utility analysis might be most appropriate. But if there are benefits of an intervention outside the health sector, so for example, if there are costs or benefits that might have an impact on sanitation or education or somewhere else in the system, and we want to be able to capture those as well as the health benefits, then cost benefit analysis might be more appropriate. So there's lots of different things to consider, which can be difficult to make sense of. So I've included this flow chart here, which I've called an imperfect guide, because it provides a structured guide to the questions that we can ask ourselves when we're choosing a type of economic evaluation. And if you go through the process of the flow chart, you get to a recommendation of the type of analysis that might be appropriate for your project. But it's an imperfect guide because there's still flexibility in the decision, even once you've gone through these questions. So the idea of this is that you would start at the top, sort of flow chart up here, with questions about whether the benefits outside the health sector are going to be relevant. If they are relevant, whether those benefits actually need to be included in the study. And if the answer is yes, then this gives you a recommendation of a cost benefit analysis. That type of analysis allows us to more easily incorporate benefits outside of the health sector. However, if costs and benefits outside the health sector aren't relevant or won't be included, then we come to the questions on this side of the flow chart about whether the health benefits are confined to a single disease area, whether we need to compare our findings to other disease areas as well. And you can see that costs and benefits are confined to one disease or condition, then this flow chart recommends cost utility analysis, because it uses a generic measure of health, allows us to incorporate benefits from different diseases. And it also allows us to compare our findings of other evaluations in other disease areas. And that can be important from a policy perspective. For example, if policymakers have to compare the merits of two different programmes in different disease areas, but can only fund one, although our evaluation might only be in one disease area, it's sometimes useful to be able to compare the results to a different study as well. It's just a sort of imperfect guide, and the idea is to guide us through some of the questions that we might need to consider when deciding on a type of evaluation. But the truth is that most of the time, any of these methods could be appropriate depending on what's going to be feasible and what's going to provide the most useful evidence in your specific context. So you might go through this flowchart and end up with the recommendation of conducting a cost utility analysis, but may decide that because of feasibility in collecting data or what's going to be most useful for decision makers, a different type of evaluation will actually be better in your context. So it's not supposed to give a definitive answer necessarily, but can be a good place to start when planning projects and evaluations to get you thinking about what's going to be the most important in the decision about which type of evaluation might be best. Okay, so I've given a bit of an overview of the types of economic evaluation, but I just wanted to mention a few other issues to consider planning and economic evaluation. We've already talked quite a bit about the importance of the benefits or outcomes that we want to include in deciding and planning our evaluation. Another thing to mention is also the cost perspective. So it's important when planning an economic evaluation to think about and decide whose costs to include, which is what we call the cost perspective of the study. And the main cost perspectives that we might use are the health system or budget holder perspective, a societal perspective, or a patient perspective. In the healthcare system perspective, we would include direct costs associated with the intervention and comparator from the healthcare perspective, but costs incurred by others outside of the healthcare system, like patient costs, aren't included. And this perspective is useful for providing evidence from a health system perspective on which services should be provided from a specific healthcare budget, which could be for a public service or a service being provided, for example, by an NGO. The societal perspective includes the same direct costs of healthcare plus productivity costs, costs of absence from work, and informal care. So this perspective takes a broader view on the costs at a societal level, and so can be useful in informing policy decisions. The patient perspective includes cost of healthcare incurred by patients and can include direct and indirect costs, but the health system costs are not included. So this perspective is useful for understanding and demonstrating the cost implications for patients and can be especially useful for evaluating equity impact. So we have to think about whose costs are going to be relevant for our projects and what sort of evidence we want to provide. And of course, it might be the case that we would want to consider more than one perspective. Another thing to mention is that we also need to consider what analytic approach is going to be most appropriate. In general, we can think about two options. One option is that we undertake our economic analysis based on primary data sources. So that means that we collect data directly within our projects about costs and outcomes and use that data for our economic evaluation. The alternative option is to use a modelling approach, which means that the impact of the intervention and comparator is modelled based on changes into the patient pathway and the associated costs and outcomes. And this approach allows data from multiple sources to be used together. So, for example, data collected in the study can be used alongside data from the wider literature. And there are also differences in these two approaches in terms of the data requirements, the time horizon, and the analytic skills needed, each of which has advantages and disadvantages which we might want to think about. So in terms of data for analysis based on primary data, we have to make sure comparative data from intervention and comparator groups on resources used, costs and outcomes is collected within our study. And this can have advantages as we're able to design data collection tools. And so we have some control over what data is available for the evaluation. But we also have to think about whether collecting this sort of data will be feasible. On the other hand, if we're using a modelling approach, we can combine data from multiple sources, which sort of has the opposite advantages and disadvantages. It means that we don't have to rely solely on data collected in the study that we're conducting ourselves, but it does mean that we're limited by the data that is available from other sources, as we don't have any control over what's collected in other studies. Although, if we know what data is available from other sources, this can inform what data we need to prioritise collecting in our own studies to fill the gaps. In terms of time horizon, analysis based on primary data means that the time horizon for the evaluation is limited to the follow-up period in the study, and so any longer term costs and outcomes wouldn't be included if we use this sort of approach. On the other hand, if we are using a modelling approach, there is more flexibility in the time horizon, and so long-term costs and outcomes can be included. So we have to think about whether long-term costs and outcomes are going to be important for our particular intervention and analysis. Finally, analysis based on primary data requires data analysis skills, whereas analysis using a modelling approach requires decision modelling skills. So we might have to think about what skills we have and where further training or support is needed. So the final thing to mention is equity. And I don't really have time to say too much about this, but I think it's really important to highlight that equity considerations are becoming increasingly important in economic evaluation, and that extensions to any type of economic evaluation, so whichever type of economic evaluation you decide to undertake as part of your projects, it is possible to incorporate an extension to that, to incorporate equity impacts. For example, we can simply consider distributional costs and effects. So thinking about sort of the distribution of costs and effects within our population of interest. Just to mention though, there are also more advanced methods. So for example, extended cost effectiveness analysis, which presents the distribution of costs and effects, but it also incorporates the evaluation of financial risk protection. And there's also distributional cost effectiveness analysis, which presents the distribution of costs and effects, but also analyses any trade-offs between equity impacts and health maximisation. And I know I've really not given much detail here, but I really just wanted to highlight that these techniques are possible so that you have some awareness and can look into them in a bit more depth if you're interested in them or think that they might be useful for your projects. As Simon said, it seems that this is the first webinar in a series, so perhaps some of these things could be picked up later on in future webinars. So that's the end of our presentation. I know it's been a relatively quick run through of the different options, but hopefully what Tim and I have talked about will serve as a bit of an introduction and an overview, which can be built upon in the future. So I think I can stop sharing now and hand back over if there's any questions.
Thank you, Professor Tim, and thank you, Dr. Bryony. It was indeed, great to listen to both of you. And obviously, you both have enlightened us in terms of, better understanding of health economic tools and also the economic evaluation. And as you rightly said, that this is the first webinar, so we have just started our journey. And definitely, if we have the specific requests, and also if you have the specific hunches from the participants regarding any deep digging on the issues that you have mentioned, we can definitely come back later on and arrange some other events like that. I think it was a quite clear presentation from Professor Tim and Dr. Bryony. I haven't seen any written questions. Okay, one question, as I can see in the box that arises, in terms of equity consideration, how people are centered at these considerations. And the second question is, how can we put this into practice? Would you suggest any resources or practical data set?
I'm not sure whether that's aimed at me or Tim, because we both talked a little bit about equity. So I think equity considerations can be people-centered, but it depends on the approach that you take. So for example, in economic evaluation, if you want to consider the equity effects, we would think about equity in terms of the distribution of costs, which could be the cost to the patient themselves, so out-of-pocket costs, and whether those are big enough to have a catastrophic impact. But it's also the distribution of the health benefits, which again are very centered around the patients themselves. Some of the other tools that Tim talked about are much more from the policy level.
Yeah, I mean, I think what we tend to be interested in when we look at the equity impacts of financing mechanisms are not so much right at the individual level, but it tends to be around group level. So if you have particular groups that you're concerned about, maybe ethnic groups or certain socioeconomic groups, and you want to know whether the benefits are getting to the poorest people living in slum areas, you can adapt your equity focus to focus on whether the benefits are getting to them. So it's around groups, and maybe quite small groups, but it's at that sort of level.
Okay, yeah. Thank you, Professor Tim and Professor Bryony. I'm just concerned about time, so we will take just one more question. We have a question in the chat box that we can see is that which tool could be more useful to get a comprehensive picture of, sources of funding and finances?
Yeah, I mean, the three tools that I mentioned are all related to each other, and they all overlap. In general, the most comprehensive picture is the national health accounts, because that's everything. That's total health spending, and the way in which the spending flows through the system. Public expenditure reviews tend to be focused on the public sector, so you can then go into more detail about the way in which budgets are formulated and the problems in budget formulation. If you want to get an intervention into the system, when do you need to talk to policymakers in order to make sure it's part of the planning and the budgeting process? It's a really important question. The PETS is more about what happens in practice, to whether the resources really do get to their intended purpose, and if not, why. So they're all important tools, and precisely which of those tools you use depends what you're worried about, really. If you're worried about leakage in the system, that maybe resources are there's some corruption in the system, and some medicines are just not getting to health centres, then the PETS tool can be a really powerful option then.
Yeah, perfect. Well said. Thank you so much, Professor Tim. And I can see a lot of interest is coming, and there is one very interesting question, which is more sort of generic, and I can resist asking that question. And I'm just assuring you that this is going to be the last one. So the person is asking how demand-side financing actually can help marginal population with health service getting.
Demand-side financing, again, it's a bit like equity analysis. You often focus on particular groups and which groups are not receiving receiving the services that they require and why. And demand side financing can be really helpful for overcoming the barriers to certain groups. Like I said, in Nepal, we were really worried about particularly people living in mountainous areas, how women would get to a health centre for delivery or hospital for delivery. And then you can really focus on them, on those groups, and put into place actions to help them overcome those demand side issues.
Thank you so much, Professor Tim and Professor Bryony and Dr. Seaman. It's just the beginning, and I would like to assure our guests that there are a lot of such webinars and seminars are upcoming under the HERN umbrella. I would like to express our sincere gratitude to our professors and Dr. Seaman for their kind presence. It certainly enlightened us and making us better understanding for the health economic tools and economic evaluation in research. So I believe that this cooperation will take place again in near future. And thank you so much for your presence again. Simon, anything you would like to add at the end?
No, not really. Just to say thanks very much again to the speakers. I thought they were both fantastic. It was really interesting to hear their stuff, and I learned a lot as well, which is always good to get from a seminar. And yeah, really looking forward to the next webinars in the series, and I hope you can all attend then as well. So thanks everyone.
Perfect. Thank you so much, and thank you Centre of Health Economics as well, and thanks for the collaboration. So we would like to say goodbye for right now. We wish you best of your health and a good journey on the way of doing economic research and in the area now of health economics. Thank you so much for attending.